Okay, well, I'm delighted to be invited to talk at this meeting, and I've been asked to speak about protecting children from respiratory diseases in Asia and the Pacific. And I'm Trevor Duke, and I'm a paediatrician and intensive care specialist, and I work throughout particularly the Oceania, Australia, and Papua New Guinea, and New Zealand, and Solomon Islands, and other parts of the Asia Pacific, and I've had a long-standing interest in pneumonia and other acute respiratory diseases. So we'll just see how we go with this talk. Well, it's reasonable to say that all over the Asia and the Pacific there are hospitals like this where pneumonia is the most common reason. Pneumonia and other acute respiratory infection, I should say, are the most common reasons why children present and are admitted to hospital. And this is Kainantu, a district hospital in the highlands of Papua New Guinea, where you can see lots of children and young infants on any particular day lined up with bronchiolitis and pneumonia, requiring oxygen therapy for and antibiotics for their treatment. So I'm going to talk a bit about a variety of things. Firstly, the overarching concept of epidemiological transitions. Now, I understand these are oversimplifications, but Asia and the Pacific region have gone through a variety of transitions, epidemiological and social and economic, that have led to changes in the way respiratory disease manifests, certainly from predominantly bacterial pneumonia in the 1980s and 1990s to predominance of viral infections, from infective, predominantly acute lower respiratory infection, infective pneumonia, to more in many countries a predominance of allergic or inflammatory diseases, and from acute to more chronic diseases. So we'll talk a bit about pneumonia and other acute lower respiratory infections. We'll talk about chronic lung disease, particularly the rising prevalence of asthma and infective chronic lung diseases such as bronchiectasis, and in some countries, obviously, TB and HIV, and the rise in risk factors for chronic lung disease, that is the greater survival of children who have prematurity and neurodevelopmental problems, and immunocompromised patients with cancer or immune deficiency have led to a new wave, if you like, of chronic respiratory disease, and all of that needs managing and prevention. And so this is the nature of the talk I'll give today. There are some serious and important trends that influence respiratory disease, and we should understand these. They're not all medical, and some include the urbanization. As you know, from 2007 or 8 onwards, more than 50% of people live in cities, and urbanization has brought with it new challenges in terms of the prevention and management of respiratory disease, partly because of pollution, partly because of crowding, a variety of different reasons, partly because of the economics of some sub-populations within urban environments, etc. COVID has obviously brought with it a major new pathogen and trends in acute respiratory disease, and that changed things a lot in the last 2 years. But it's just one of the secular trends that have led to, I guess, a change in the way we can consider acute respiratory disease. There is increasing antibiotic resistance and exposure to antibiotics that have led to some changes in the way we need to think about pneumonia and other respiratory disease. And then I think increasingly, as I sort of alluded to, there is more heterogeneity than ever before in the etiology, in the viral and bacterial causes of pneumonia and other respiratory disease. And there's also heterogeneity in terms of risk factors. And I think we have to be better at understanding risk factors for respiratory disease. A few years ago, I made up this slide because I wanted to demonstrate that all pneumonia is not just due to pneumococcus and Haemophilus, and the proportions of cases of pneumonia and other severe acute lower respiratory tract infection that are due to other pathogens are considerable and increasing. And this is, if every country could have like an antibiogram, there is a proportional causes of pneumonia. And in Papua New Guinea, at least, about 20% of all cases of pneumonia are due to pneumococcus, and about 15 to 20% are due to Haemophilus, often non-typable Haemophilus. Then we have some pathogens that are perhaps one could say a bit more opportunistic, that is Staph aureus or gram-negative bacilli, and they tend to be more commonly found in more susceptible hosts. And then we're increasingly understanding that at least about a third of all respiratory infections are due to respiratory syncytial virus, and then a smaller proportions due to other respiratory viruses that come in outbreaks and waves on any given year. So influenza A and B and parainfluenza, and human metapneumovirus, which is quite common, and adenovirus, which comes in waves and might be small in proportion, but often causes more severe disease. And then we understand that a proportion of children who even present with acute respiratory infection each year will have, they present with relatively short history, will actually have Mycobacterium tuberculosis. And so I think in the last decade, we've understood that even though children might present with relatively a short history, they still, a proportion, 5 to up to 10% in some studies in some countries, can have Mycobacterium tuberculosis. And then there's the atypical, so-called atypical infections of Mycoplasma pneumonia, causing 5% or more of acute pneumonia in children, obviously more in older children, and chlamydia causing pneumonia in young infants, particularly under the age of 3 months. And then Pneumocystis jirovecii, again, an opportunistic pathogen, but in some countries, such as in Papua New Guinea, it is something that we don't want people to forget, especially in the HIV-affected populations, and maybe also in other populations of children with severe malnutrition. The PERCH study has, the pneumonia etiology research for child health study, has given us, I think, reinforced this understanding that the etiology of pneumonia is heterogeneous. And of course, that pneumococcus and Haemophilus are still the predominant and most important and most preventable causes of pneumonia, but that there are other pathogens that are relatively common. And this was a study done in over 4,000 children with severe or very severe pneumonia in 7 countries, only 2 of which were in Asia, but in 7 countries, I think representative really of the world. And this is the proportional etiology of acute respiratory infection in such children. And again, respiratory syncytial virus tops the list with just over 30%, and was uniform across all countries. So it's universal as causing about 30% or a third of all cases of acute respiratory infection. And then at different times, these other pathogens were predominant. But these pathogens were the I guess universally found in all countries to be important in the etiology of pneumonia. Human metapneumovirus, parainfluenza. Pneumococcus in this study contributed to about 10%, up to 10% of all cases of pneumonia. I think in some countries that haven't quite gone through that epidemiological transition from bacterial to viral, then pneumococcus is going to be more common, like in Papua New Guinea. And similarly, Haemophilus will be a bit more common, where the density of nasopharyngeal carriage of Haemophilus and pneumococcus in young infants is a major part of the etiology. And then, as I said, Mycobacterium tuberculosis causing somewhere between 1.9 and 10% of all cases of acute respiratory infection in these populations. So depending on the endemicity of TB will dictate just what proportion this is commonly. Notably, in these children, 30% of them, or 32%, had wheeze on auscultation, and I think it tells you that a lot of the what we've been calling acute, severe or very severe pneumonia as WHO criteria also is associated with bronchiolitis or airways disease. And there's no reason why some cases of pneumonia, that is acute lower respiratory tract infection with consolidation, can't also have airways disease, and the two overlap rather considerably. In this study, just about 50% of all children had no consolidation or opacification on chest X-ray, and again, it just tells you that a lot of it, what we've called severe and very severe pneumonia, actually is acute bronchiolitis, and obviously viral bronchiolitis was very common in this study, and as it is throughout the world with RSV and paraflu and human metapneumovirus predominant pathogens in that setting. The thing about the etiology of severe acute lower respiratory tract infection is that it is more complex even than that. And that is that there's often not just one pathogen. And sometimes there's one pathogen, of course, but often there is the stages to the development of severe pneumonia are that there's an upper respiratory virus that is circulating in the household or the community, and that's followed by nasal mucosal damage and inflammation, and then drip aspiration of mucus secretions, and whatever nasopharyngeal bacteria are colonizing. And in populations where there's heavy colonization with pneumococcus and Haemophilus, what the infant aspirates, drip, post-nasal drip, if you like, aspirates when they have a viral infection, is often Haemophilus or pneumococcus, and sometimes that just sits there in the lung. There is a concept of the lung microbiome now, and sometimes that flares up and causes pneumonia. Now, of course, most children recover with antibiotics, even if they have so-called viral bronchiolitis. In some settings where there's often mixed viral and bacterial infection, then most children recover with antibiotics, and probably quicker with antibiotics. But some, of course, don't need them because all they have is a virus. And so increasingly, we need to try to understand the proportion of children with bronchiolitis who no longer need antibiotics. Depending on the stage of that epidemiological transition, there will be higher proportions that with mild bronchiolitis or mild to moderate bronchiolitis who actually don't need antibiotics, and that's an important question for the future. There is in understanding the etiology of acute lower respiratory infection or acute lower respiratory disease, we see many children that have recurrent acute lower respiratory infection. And of course, for many of these, it's not acute lower respiratory infection, but it represents asthma. And asthma or recurrent airways disease, bronchospasm in response to acute respiratory viruses. And I guess increasingly we need to understand that every child who presents with acute respiratory deterioration or acute respiratory symptoms doesn't always have pneumonia. They're probably the most common, in some communities, the most common reason for a recurrent acute lower respiratory infection is just recurrent viruses, and the same causes can occur on multiple occasions. So some children who have some risk factors for getting RSV can have multiple RSV infections, even in the one season, one virus followed by another, or different viruses, or two or three viruses at a time, especially in children that come from households where there are risk factors, I suppose, for more severe acute respiratory infection. And then sometimes with this recurrent acute lower respiratory infection, the children that come back to our hospitals or represent on many occasions, sometimes that acute lower respiratory virus is followed by a bacterial bronchitis, the colonization of the airway with Haemophilus, or particularly Haemophilus, but sometimes in susceptible hosts with staph, or in debilitated or immune compromised children with Klebsiella or Pseudomonas occasionally, but typically Haemophilus causing chronic wet cough, and that can be a part of the etiology of recurrent acute lower respiratory infection. And then, of course, as I said, tuberculosis, where children can present on multiple occasions and can seem to improve a bit with antibiotics, but then go home and then deteriorate further. So always think of TB. Remember, 5 to 10% of all cases of, or in the PERCH study, 1.9 to 10% of all cases of acute lower respiratory infection were due to tuberculosis. I think the implications of these different pathogens and different factors are that vaccines are necessary. The vaccines for pneumococcus, the conjugate pneumococcal vaccines and Haemophilus vaccines, they're very necessary, but they're not sufficient. And that what we need instead is a comprehensive program of the prevention of respiratory disease that's relevant to country needs. And I sometimes think of comprehensive childhood respiratory programs a bit like this. There are many examples of such programs in different countries that have evolved over the years. Successful examples in the Philippines, in Malawi, for example, in Papua New Guinea, I've seen various programs for prevention of childhood respiratory disease. And all countries have components of these, and sometimes it's useful to think about it as a comprehensive childhood respiratory prevention program. So obviously vaccination is a big part of it with conjugate pneumococcal and Hib vaccines, but also having as higher coverage of measles vaccine and pertussis vaccine and BCG, and even now the consideration of the effect of the COVID vaccine on childhood respiratory disease, which I won't go into. As I said, vaccination is necessary, but not sufficient. So even that's the top line, the first dot point. There are many, many other interventions, preventative and curative, that are just as important, I believe, in a comprehensive childhood respiratory program. And that includes improvements in rates of breastfeeding and improved nutrition in the first 2 years of life. The susceptibility and risk factors for acute respiratory infection include the waning effects of breastfeeding after 4 to 6 months and inadequate complementary feeding in the first year or two of life. I mean, that's and sometimes inappropriate feeding in the first few months of life can lead to pneumonia in some communities. The protection from indoor air pollution and cigarette smoke exposure is fundamental. And again, this is very context dependent, and there are some communities where indoor air pollution is very high because of economic problems and technological issues, where fossil fuels are still used indoors in the absence of chimneys and other mechanisms to remove smoke, and many communities where cigarette smoke exposure is still high in infants. There are programs for healthy housing that can make a real difference to acute lower respiratory infection, that can prevent overcrowding and have improved ventilation and improved management of dust and mold. I mean, these are all etiologically related to acute respiratory disease and chronic respiratory disease in children, and a program to protect children from acute respiratory disease would certainly address healthy housing and prevention of indoor air pollution and improved nutrition. And then there's basic aspects of childcare. So healthy childcare, a bit like healthy housing, so emphasis on hand washing, which is in some cultures is very highly prized, and in others it's less. There's less education about hand washing and cleanliness. Avoiding bed sharing where possible, but that relates to healthy housing and avoiding overcrowding, etc. And then early care, seeking better education for parents on the signs of acute respiratory disease, or in the treatment of acute and chronic respiratory disease is very important. So they're preventative interventions. A comprehensive program for prevention of acute respiratory disease would have. And then there's many issues about quality of care in hospitals and in health facilities, including improving oxygen therapy, including monitoring and supportive care, that risk analysis I talked about before for identifying children with high-risk respiratory disease, improving guidelines and training along the World Health Organization guidelines, management of comorbidities, because as I said, there's transition to more respiratory disease in children who have underlying chronic conditions, means that such comorbidities need need better management. And then there's management programs for asthma. In some countries, the strengthening of TB and HIV programs has led to improvements in the respiratory disease. Particularly, I've seen more recently in HIV programs where the upgrading of children from older antiretroviral therapy to more modern dolutegravir-based therapy, for example, and programs to improve respiratory hygiene have led to a reduction or an improvement in children with chronic respiratory disease. And then I think that programs of care for children with chronic illness, as I said, these are the children with the greatest risk of respiratory disease these days. We need to focus on. The evidence for protection from indoor air pollution is fairly strong now, although the empirical evidence, the sort of randomized trial evidence, is not as strong. But I think that increasingly we understand that methods of household heating that have an adverse effect on the environment, like if you're using coal or wood or gas, they are associated with increased acute respiratory infection, and the components of that, maybe carbon monoxide or black carbon, a particulate matter within smoke, and in some programs that have improved the reduced indoor air pollution, there have been reductions in acute respiratory disease. Not all, but in many, there have been reductions in the incidence of acute respiratory disease and acute chronic respiratory symptoms that children have. There's some evidence that improving, again, on healthy housing, there's some evidence that that links mold and dust, certainly, to acute and chronic respiratory disease. And the studies that have linked this, particularly mold, have been strongest in China. Many studies out of China linking mold with acute and chronic respiratory disease. There's also strong dose responses from Taiwan. And one important study, I thought, from native Alaskans that showed the link between mold and respiratory disease. There is only one intervention study that reduced mold counts in households. That's from New Zealand, and that reduced the symptoms of asthma and other chronic respiratory symptoms and days off school and healthcare utilisation for respiratory disease. And the authors of that study concluded that probably combined home interventions were most likely to be effective. So not things that just reduced mold, but also reduced dust, reduced overcrowding, and reduced indoor air pollution. I think so. An overall program for healthy housing is fundamentally important, especially in the highest risk populations. We know that pneumonia and respiratory disease also affects newborn babies, and I just put this slide in because we shouldn't forget neonatal pneumonia, and the ways to prevent neonatal pneumonia are a bit different than for older children. But if we put emphasis on clean deliveries and prevention of low birth weight and prematurity and other measures to improve neonatal health, then there will be a reduction in respiratory disease, particularly pneumonia in children. That also overlaps a lot with the smoking exposure and reduced parental smoking of mothers and fathers during pregnancy, and reducing in utero smoke exposure is very important, as is in many populations the prevention of sexually transmitted infections, particularly chlamydia, but others as well, that clearly have a etiological risk for pneumonia in those children. There's some evidence that antibiotics exposure in newborn babies increases the risk of asthma in later life, and I think that the evidence for this is moderately strong now. And so whatever we can do to reduce antibiotic exposure in the neonatal period is probably a good thing, both for the microbiome in the gut for the risk of resistance in our special care nurseries and neonatal units, but also potentially in the reduction of chronic respiratory disease in later life. We, as countries transition from focus on pneumonia to respiratory viral infections and asthma, a bit more from infective to inflammatory and allergic, then we need to be better at many countries have already made this transition, but some countries have still not got more modern methods of management of asthma, particularly the availability of metered dose inhalers and spacers for children, and also the preventative medications that we now know to work better, and including budesonide formoterol. Symbicort is the trade name, which is now for budesonide and formoterol is now on the WHO essential medicines list, and this is a very important innovation because it's for children over the age of 5. It's probably the most effective preventer that can be available for children with recurrent severe asthma. Of course, many countries need guidelines on the management of asthma that go beyond just the use of just acute asthma. And I think the management of chronic asthma is now a focus of the World Health Organization, and hopefully that will change the situation in many countries, especially the use of budesonide formoterol for children who've got severe chronic or recurrent asthma over the age of 5. Now, some countries are still in the phase where a lot of chronic lung disease is chronic bronchiectasis, and of course there is overlap between bronchiectasis and airways disease, but in some countries where there's a heavy burden of respiratory infections, be it TB or HIV, or even post-viral infections with adenovirus or other viruses, and then bronchiectasis is common. And I think that in the past, bronchiectasis was considered to be a condition for which not a lot could be done, but I believe now quite a lot can be done with using programs for the management of chronic respiratory disease, be it children who've got preterm prematurity chronic respiratory disease, or they've got bronchiectasis. There are things that can be done to improve the lives and respiratory outcome of these children. I won't go through these, but they include things like improving nutrition, low-dose antibiotic therapy to reduce the flare-up from colonizing bacteria, and a variety of other things that manage the complications, the fluid accumulation, or even the airways disease component of such children. And I've seen this being more successful in many countries in recent years. And then, as I said, programs for chronic disease management. I think our hospitals have been very good at managing acute illness and acute complications. We do that very well, but we're less good at chronic disease, models of chronic disease management. And so I think we need a transition in the way hospitals and health services function that has to include more training on chronic childhood diseases, not just chronic respiratory disease, but that's a big component of it, and systems that link hospitals with community services so that children don't just get treated as if they've got an acute disease and then sent home and then come back when they reach a certain threshold for becoming unwell again, but have some preventative aspects to their chronic disease management. I won't go through this, but this is relevant to chronic respiratory disease and to also other chronic diseases of childhood where respiratory complications are likely. And one common component of this is to have individualized management plans for children who've got chronic disease, be it respiratory or otherwise. Individualized management plans for children with asthma or bronchiectasis or chronic lung disease from prematurity or whatever it is. As I said, I've seen recently the success of chronic disease management programs in various countries, and I think this is just beginning, but I do think that this will improve the way illness is pneumonia and chronic disease is managed throughout the Asia and the Pacific region. And this is an example of a child who has HIV, who has gone from having severe chronic bronchiectasis to having much improved lung function, with an improvement in the non-respiratory aspects of his care, with the introduction of more sophisticated antiretroviral therapy that's reduced his viral load, and a program to improve his overall respiratory management. And I think that as we transition more from just acute disease to being better at the management of chronic disease, then I think we can help children who both have acute pneumonia or acute bronchiolitis, but also children who have chronic respiratory disease. So I'm going to stop there, and thank you for your time, and I wish you a very good conference for the rest of the time. So thank you.